So the first question was discuss the diagnosis of unruptured ectopic pregnancy, and this had a marking of 4, and the remaining 6 marks were for a patient who was a 30-year-old gravida, 11 days overdue and asymptomatic. She is reported to OPD with an endometrial thickness of 8 millimeter on a TVS and beta HCG raised. This is, what does this mean? You've been asked to discuss management of PUL. What is PUL? PUL is pregnancy of undetermined location. So let's see the question. Let's see the answer. So the first part was that discuss the diagnosis of an unruptured ectopic pregnancy. So introduction, it may not actually be required to give an introduction because it's not going to give you extra marks, but still I wrote this. When a fertilized, so basically, what is an unruptured ectopic pregnancy definition? Okay, but this is not important. You can actually omit this step. What is important in diagnosis is, of course, number one, clinical features, right? Patient comes to you, always do a history and examination. So symptoms and signs. Symptoms we know is the classic triad of symptoms. So amenorrhea, bleeding, okay, and pain. This is your classic triad of symptoms in ectopic pregnancy. Then we have the signs. Signs is adnexal tenderness, cervical motion tenderness, uterus may not necessarily be enlarged, but yeah, it will not correspond to the gestational age. Now, laboratory investigations would be next. In investigations, we have serum beta HCG levels, and which is the most important, and complete blood count. And then imaging. So imaging, we will of course do a transvaginal scan. This is in fact the most crucial tool to diagnose ectopic. What are the findings on the TVS? You can mention an empty uterine cavity, then the bagel sign, the blob sign, the ring of fire sign, all that can be mentioned, right? The ring of fire on Doppler. So this is what you'll mention, the clinical features, that is symptoms and signs. Then you'll mention the imaging, TVS, and blood workup, that is beta HCG, and maybe a CBC. This is going to be your diagnosis, right? Now, the next part of the question. The next part of the question is, how will you manage pregnancy of undetermined location? Now, what a PUL can be, it could either be a failing intrauterine pregnancy, it could be a recent abortion, it could be an early, especially if she had a history of bleeding, it could be an early intrauterine pregnancy, or it could be the most worrying thing, it's maybe an ectopic pregnancy. So how do we manage PUL? The most important is serial beta HCGs, right? And for this, the best way to answer such a question is just make a flowchart. PUL is always best answered as a flowchart. And this flowchart is from the RCOG website. So PUL, what do? You see if she's stable, but having pain, consider laparoscopy, because when she's having pain, you can't ignore that symptom, right? But if she's unstable and having pain, again, you'll do surgical. But if she's stable and she's pain-free like this patient, here you need to know what it is. So the best thing is to do a serum beta HCG serial monitoring, and you're looking for a decline or a rise. If the decline is there and it's more than 13%, it is wherever the pregnancy is, it's failing. So we're not that concerned. If it's rising and the rise is more than 66%, again, we are happy because this is likely to be a normal intrauterine pregnancy. Repeated TVS on day 7 or once the beta HCG crosses the discriminatory zone. But if the increase is there, but it's less than 66%, or if the decrease is there, but it's less than 13%, then you will think of an ectopic pregnancy. What do you do then? You will either repeat TVSs, repeat a TVS, or monitor with weekly beta HCGs. Also, there is a role here of considering injection methotrexate. If the diagnosis still remains in doubt, then methotrexate can be considered. So this question is best answered in the flowchart form, right?